No problem.
Okay, recording now started. Dr. Joel Branch, I think everybody knows pretty well. He is from the originally United Kingdom and then general practitioner, basically internal medicine. And then live in Japan many years and excellent teacher. And he's helping my education in Japan maybe more than 10 years or 15 years. Particularly going to the Okinawa and now Shizuoka medical center, we are doing some bedside teaching, so he's coming and then teach us. Today, sorry about the title, but he's gonna, discuss about H&P, history and physical. And basically, I think participation is probably very important. So
Absolutely.
please, participate in discussion and don't worry making any mistake or anything. So
that's right.
Now I baton touch to Joel. Okay.
Okay. Thank you very much,
Yeah,
Dr.
go ahead.
Machi. Thank you, and thanks to Emmy as well for coordinating everything today. Okay. So as Dr. Machi just said, I'm Dr. Branch, and I work in Shonan Kamakura General Hospital in Kamakura. And I've been working there for 15 years, and I increasingly have been helping Dr. Machi over the years in various projects, and it's expanded and expanded. So we're also doing this project as well, which is very exciting. Now, I want to find out from the participants at the moment, how many of you understand my English?
Yay.
Because many of you have your videos switched off. So I can't see you. So I don't know if you're understanding me or not. You're hiding behind an empty screen. So I don't know. There's half of you that I can't see.
So how about if you understand and then I cannot turn on the video, there's a reaction things, right? Like this. Yeah, you can mark this reaction.
That's right. There's a thumbs up.
Yeah, can you do that?
Could you give me a thumbs up if you understand or not? We got one thumbs up. Are you okay? Okay. Yeah. Okay. If you don't understand, the thumbs down.
There's no
I don't know what
down.
it is. If it's halfway between, I don't know about that.
I guess mostly said okay. I guess this thumbs turn off quickly. So
they do. If you do not understand, please speak. That means unmute and say something, please, or write a comment that you don't understand, please, and hopefully Emi-san can help with that. Okay. Now, can I just ask, what year of medical training are you in? Are you preclinical? Are you clinical students? Are any of you postgraduates? What
how about medical student 1, 2 or something like that? Can you?
もしチャットに数字を書ければ、学年
書いてくれてもいいし。
医師の方は既卒年数でも構いませんので、チャット機能わかりますか？下にありますよね。皆さんの学年を知りたいそうです。
じゃあもう手挙げても見えない人がいるんだな。
If you see the chat box, typing in.
Okay. Right. So some of you are first years, second years. Some are third, fourth. There's one fifth year, it looks like. Okay, so a kind of a whole mixture of people. Okay, so I will try to talk at a level where most, if not all of you, can understand what I'm wanting to say. Okay, so let me begin. This is going to be an interactive session. I'm not just going to talk. I need you to help me, because I need to know that you're understanding and thinking. And if you just sit there behind your screens and just listen, you're not going to learn. So I do need you to interact with me. Otherwise, I might as well just go and talk to myself in the mirror, because it's the same difference. So I need you to speak to me, please. Because doctors speak to patients, or at least they should do. So, and if doctors can't communicate with each other, you might as well go and do a different profession. You might as well become a forensic pathologist who speaks to the dead. Same difference. So I need you to speak to me today, please. Okay, we need to exchange ideas. Okay. So, you're all training to become doctors. Doctors, as I just mentioned, have to speak to patients. And that's what's called history taking. They have to take a history from the patient to try and understand what's wrong with the patient. How do you take a history? How many of you have actually started to take histories from patients? Can you give me a show of hands? Let me go to the chat box. And how many of you, could you just say yes or no? How many of you have actually started to take histories? Yes or no?
何をしたことがあるかということですね。
Okay. Right. Not yet. Okay. No, no, no. Most of you have not started to take histories from patients. I see.
I think first year usually not yet,
Yes,
I guess, but
that's
yeah,
right.
from the second year, maybe not. Third year for sure they must have been done.
So I would not, from this point onwards, I want some of you to start turning off the unmute, and I want you to be talking to me. If not all of you, take turns. Why do we even bother to speak to patients now? We've got CT scanners, MRI scanners, scanners, lab data, more scans. Why do we need to speak to patients? Can you tell me? Is there any reason, or do you even need to go into medical training at all? Can you tell me? Any ideas? If you don't speak, I will pick people, and I don't like pimping people, but I will do if you don't turn off your microphone, if you don't unmute. So who wants to get pimped?
Can I speak?
Oh, yes, please. Who am I talking to?
I'm Yusuke Yoshida, first year student from Juntendo.
Great. Hi.
I think by asking patients, you can sometimes determine the infections and what types of infections they have by asking, for example, what they have eaten or like what types of problems they have. By asking what types of ailments they have already, you can maybe pick the right treatment for them. And if you don't do that, I think you might do something to the patient that's not very appropriate. And so I think asking patients about some questions is very important.
I agree. Very nice response. Excellent. Thank you. Do you have anything else you'd like to say? You're saying very good things at the moment. You don't have to.
Yeah.
It's an option. Okay. And so you're from Juntendo?
Yes.
And you're a first year medical student?
Yes, first year medical student.
I'm very impressed. Very good. Thank you. Thank you very much. Does anyone else have any idea about why you take a history?
Excuse me.
Yes, hi.
Yeah, can you hear me very well?
I can hear you well, thank you.
Yeah, yeah. First, I'm also from the 2020 University, and right now I'm in the 5th grade, and one more year to pass the final exam.
Oh, great.
And I think it's really important to communicating with certain patients just to, we need to know the whole background of the patient, including the, have you been going to the other countries, and about the patient's social activity, including do you drink, do you smoke, and all of that things are not included in the examination of the MRI or the CT. And if this certain patient is got some has a really bad headache and got a high temperature, body temperature, and we need to ask somebody else in your family has the same symptom like you, and all of those things cannot be seen in the medical examination like the CT and MRI. So that is why we need to talk to patients.
Excellent.
Yeah.
Thank you. Very good indeed. Thank you. Thank you for your comments. Thank you. Does anyone else have any ideas about why we have to take a history?
Excuse me.
Yes, please.
Can
Yes.
Can you hear me?
I can.
I'm Yuki Nakagawa, Kochi Medical School first year student, and
Yes.
I think we have to speak to patient because we have to understand and share what the patient are thinking or where worried about. As when we talk to the patient can share what they are thinking, and so they can face exactly what they are talking against. So I think we have to talk with patients.
Very good. Thank you. Thank you for your contribution there. Thank you very much. Very good. Anyone else? I mean, we've had 3 people talking just now, and each one has said slightly different things, and they're all correct. All correct. So I'd like to hear any other opinions. Anyone else want to say anything? Don't be shy. Oh, I see Tanaka Ayako-san has the same background as me on Zoom. We must be in the same location. I can't see you. I'm looking, but I cannot see you. You need to wave. So, Ayako-san, can you tell us, in your opinion, why we need to take a history from patients?
One more thing I can add to their opinion is that we can share what exactly the patient has more like worried about or more having bad feelings by just talking to the patients. For example, in taking MRI or CT, there are signs of strokes or something like that, but the patients actually have other like symptoms than the symptoms from the signs. So we need to talk to the patients.
Good. Thank you. Thank you. Okay, so let me just see what I can do with this whiteboard here. So I switched to the whiteboard now, and yeah, I got my pen there. Okay, so why do we take a history? So history is primarily we want to try and find out what's wrong with the patients, don't we? Yeah, so it's to identify what's wrong with the patient. Okay, but first of all, in order to get the patient to talk to us, we have to gain their trust. Just because we wear a white coat, and by the way, I don't wear them, by the way, but many doctors still do. Just because you wear a white coat does not equal that the patient trusts you. And I know this from firsthand experience with my own family in Japan. Some of them do not trust doctors. And they've had very bad experiences with some doctors, and primarily because they're poor history takers. And they don't show any empathy or rapport. So doctors are not just there as kind of getting the information. They have to show that they are caring human beings, because that's what we're in this as what's called the caring profession. The caring profession. And so doctors need to show caring. Okay, so there's lots of elements involved here. So a caring attitude and empathy. Okay, they need to have a good ear to listen to patients. Yeah, and it's to make a rapport, which means a good doctor-patient relationship. Okay. Now, you may well have seen some doctors working in a kind of paternalistic way. Do you understand what paternalism means? Paternalism means fatherly figure. It means the father talks down to the child and the child says, hey. That's not what doctors do. In the past, that's what doctors did. It's on in some places in the world and in this country as well. And that is a very old-fashioned way of doctoring. The more modern way, which is in the UK and the United States, including Hawaii, is that doctors and patients are on the same level and they discuss the information as two human beings. So you need to make a good doctor-patient relationship. And this is how you do this, and it's through history taking, the process of the interview. Okay. So, as I mentioned, we're primarily wanting to gather information in order to try and make a diagnosis of sorts. So, how do we get this information exactly? What do we say to patients? How do we start off the interview? Because most of you have said you haven't done any form of history taking yet. So how do you start off an interview? Please jump in. How do you start the interview? That's a question. Please answer.
Perhaps introducing yourself to the patient.
Yes, good. So self-introduction. Anything else? Anyone else have any ideas? So you introduce yourself, yes, and what do you say to the patient once you've introduced yourself? It's very simple. Don't overcomplicate it.
Can you hear me?
I can indeed.
I think make sure the patient's name is the first.
Good. Okay. Is it the correct patient? And? Yeah, sorry. Who wants to speak? I can hear somebody. No one? It depends on what setting you're in, really, isn't it? You may be in the outpatient clinic. You may be on the ward. You may be in the emergency department. So it may differ to some extent. But if, for example, you're in the outpatient clinic, maybe you've had a referral letter from another doctor. So it may be for a second opinion. So you may have in front of you their letter. So you say, oh, I've received this letter from your doctor, who is Dr. Smith, for example, or Dr. Murata, or Dr. Alkage. Did you? Yes. So, and then you say, oh, your doctor has said that you have this problem. So you're starting off with some background information to the patient and then allowing the patient to speak. So that could be one way of introducing. Or maybe you are in the emergency department and you've had a referral from the emergency doctor who's seen the patient prior to you. And you say, oh, Dr. Kabun has just seen you and referred me to you, and you have this problem. Can you tell me more information? Or maybe you're seeing the patient fresh. And then you may say to the patient, why are you here? What's wrong with you? What symptoms do you have? Okay, so there's various ways about starting the interview. Okay. So I think that's an important point. You may well have other information that you need to read before you see the patient from other doctors, or you're seeing the patient fresh. Okay. Does anyone have any comments or questions at this point? Anybody? Okay. So in which case I shall move on. So we're here to gather symptoms from the patient. Now, you may well have heard the word chief complaint. How many of you have heard of this term, chief complaint? Chief complaint. Can you put a thumbs up if you've heard of this before? Or a thumbs down if you haven't? Thumbs up we've got, yeah. Yeah. Okay, so some of you have heard of chief complaint. Now, this is a term which is used in the United States. And there's a difference between what's used in the UK. So in the UK, it's called presenting complaints. And that's plural. And I'll explain the difference. Now, from what I've experienced from living in Japan, there is a lot of American influence on medicine, Western medicine in Japan. So when I came here, I was introduced to this term chief complaint. And I said, hang on a second, there's only one complaint. Patients don't present with one complaint. They have multiple complaints. But chief means what is the major complaint? What is their main complaint? So that, for example, they may have 3 or 4 symptoms. They may have chest pain, they may be breathless, they may have a fever, they may have a cough. But the main complaint may be chest pain or it may be fever. So that's why it's used as chief complaint. However, that can be confusing because it to some people, they may say, oh, the patient only has one problem. But that may not be true. It may not be true. They may have multiple problems or multiple symptoms. And so I like to use the term presenting complaints. So they still have complaints, but they're allowed more than one. And these are what they present to the hospital with, or they present to the doctor with, presenting complaints. Now you can use whichever one you like, as long as you remember that patients don't just present with one problem. They usually, most of the time, present with multiple complaints, which are hence symptoms. Complaints and symptoms may well be the same thing, but not always. They may be complaining about the doctor. So it's not always symptoms. Okay. So this is an important thing to remember. So when you start to take a history, you need to label up. The first thing you label up on your history taking is either chief complaint, CC, or PC, presenting complaints. Okay. So let's go to the next slide here, and we can then put up here. I'm going to use the term presenting complaints. So for example, let's imagine we have a patient who presents with chest pain, dyspnea, which means ikikurushi, or yeah, ikikurushi, and then full, and let's say loss of consciousness. Okay, hey. Now that's a nice little list there. Can we make a diagnosis just from that? Can we say, oh, I know that diagnosis now. They've got 4 symptoms. I know the diagnosis. Can you do that? Who thinks they can do that? If you can, I would challenge you to take on Dr. Tierney for that. If you don't know who Dr. Tierney is, Google him. I would argue that you cannot make a definite diagnosis from this. Okay, so how can we make a diagnosis from these symptoms? Question. I'd like your opinions, please. Please feel free to jump in. Or I shall pick somebody. Okay, Murata-san. How can we make diagnosis from these symptoms? What do we need to do to try and make a diagnosis here?
Okay. So I'm sorry, I can't hear you now.
Okay, I'll ask the question again. From these 4 symptoms here on the whiteboard, how can we try and make a diagnosis? What do we need to do further in the history taking process?
You mean like that? What should I for the next question?
Yeah.
So in my opinion, or I will ask what area the chest, where the chest pain is.
Okay.
More, yeah. More specific, more specifically.
Okay, so the site of the pain, yes?
Yes.
Anything else?
And when does it start?
Okay, so the onset.
Yeah.
Yeah.
And when or where do these symptoms get more serious?
Okay, so exacerbating
Yeah.
factors. Okay. Okay, so let's put that there. Oops. Exacerbating factors, yeah. Anything else? Notice there's a bit of a gap, which means you need to fill stuff in. So there's missing letters. There's missing information.
Okay.
Yes.
I have no idea now.
That's okay. Thank you. Thank you for giving me that information. Does anyone else have any other information? They can help fill in what I'm wanting to write on the whiteboard here.
Excuse me?
Yes, please.
Yeah, I'm sorry. It might be a little bit noisy around me.
Don't worry. That's okay.
Yeah. And since she has already talked about the onset and I'm sorry, what is the first word before the onset?
Site. S-I-T-E. Yeah.
And since I was taught to ask about the OPQ or ST.
Yes.
Yeah, and I think the next things we need to ask about is the quantity of the pain. Or how's the pain is like?
Or character. Yeah.
Yeah.
So as I'm writing a different mnemonic to you, yeah. Anything else from your OP curiosity?
Does the pain moves to from one place to another?
Okay, so radiation. Good.
And severity of the pain from 1 to 10, how the pain is like.
Okay.
Is that right?
Yeah, severity. That means that there's a few other letters missing here.
What is the timing of the pain? When does the pain come?
Okay, so that means there's one more word missing.
Yeah, it's just, does the pain come from the morning or the afternoon?
Oh, that would be the timing or the onset for that. Yeah. The one that's missing is alleviating factors, things that make it better. Okay, so this makes a different mnemonic. Oh, I don't like that color. Let me try a different color. Let's try red. Yeah, this makes the mnemonic Socrates. So it's slightly different from OPQRST, but if you like Socrates, you like Greek, Socrates. So you can remember the site, onset, the character, the radiation, alleviating factors, timing, exacerbating factors, and severity. You can also use the S at the end for social effect. How badly does it affect you? So that's to try and find out about one aspect of and that's just the chest pain. And within that chest pain set of questions, whatever the patient answers you may send you off into more questions and more questions and more questions. And we'll come back to that maybe in a second. Now, I wanted to go through something a little bit more basic and fundamental. I've written these symptoms down, with dots. I haven't written them down as 1, 2, 3, 4, although you can do that. Are they in the right order? And does it matter? We've got chest pain, dyspnea, fall, loss of consciousness. Does it matter what the order is? Or is it okay like this? What do you think? Have you ever thought about that? The order of the symptoms. Can it change your diagnosis? Let's ask. Who can we ask? Shall I go on a pimp? Shall I pimp somebody? Fujimura-san. Mayumi, can you hear me? Yes, hi. How are you? Yeah, you're smiling. You looked a bit unhappy just now. Are you okay?
Hi.
Good afternoon. Yes.
Good afternoon. So you mean after question for patient, so what should doctor do?
No, it's much more fundamental. For example, they may say, I've got chest pain, I feel breathless, I fell down and I've lost consciousness. Or I lost consciousness. The patient may not tell you in the right order. But for example, if you don't ask that, can you still make a diagnosis accurately?
The patients that don't tell anything.
Well, whose job is it to tell? Is it the job of the patient to tell the doctor, or is it the job of the doctor to ask the patient the correct information? Which is it? Do we blame the patient for not telling us properly, or do we blame ourselves for not asking the right history?
質問をちょっと訳してもらってもいいですか？
すみません、どのような順番でそれぞれの症状が起きたかっていうことを患者さんが医師に正確に伝えるのは難しいかもしれないので、医師が聞かなきゃダメですか、それとも患者さんが言うべきですかっていう質問。
日本語でも難しい。順番。
医師が患者さんに聞いた方がいいですよねっていう、患者さんが医師に正確に伝えられますかっていう。
Okay. This patient have consciousness, so I think difficult to explain about the situation. So doctors should ask questions and diagnose and decide what happened. Decide doctor should do.
Okay, thank you. Thank you very much for your comment. Thank you. What I want to do is try and show you that the order of the symptoms is very important because it may change your diagnosis depending upon that. So I'm going to go to another whiteboard, a fresh one, and I'm going to write up here in a different order. So let's say the patient presents with chest pain. And we do it in the order that we're told: dyspnea, falling down, and then loss of consciousness. So I know that many of you have not done any clinical medicine yet. You probably don't know much in terms of pathology either. So can any of you think about what kind of diagnosis should you consider given this order of symptoms? First of all, chest pain, then breathlessness, falling down, loss of consciousness. Can you think of any diagnosis that you should consider here?
How about the myocardial infarction?
Okay, so maybe an MI, massive one. Usually small MIs, won't do that unless they cause maybe a dysrhythmia, so an abnormal heart rhythm. Okay, what other diagnoses to consider given that set of symptoms?
And how about the pneumothorax? I don't know.
Okay, so a tension pneumothorax, kikyo. So a collapse of the lung, onset of dyspnea, maybe hypoxia, low oxygen level, falling down, loss of consciousness. Okay, good. So tension pneumothorax, kikyo. Anything else?
P.
Yes, hypoxia, pulmonary embolism. Good. What else? It's a bit more difficult now. Well, I always have on my list aortic dissection. We have Machi Sensei here, who is a surgeon, who will want to see that on the list. Aortic dissection. I can see Dr. Machi smiling there, going, yes, that's right. Okay, so aortic dissection needs to be on that list. Those would be at least the initial ones to consider. Okay, we'll keep it simple like that for the time being. Now let's change the order here. Let's change the order, and let's say the patient has loss of, let's say they have a fall, loss of consciousness, chest pain, and dyspnea. What about now? Is it the same diagnosis? Can you think of any diagnoses now that are different? It's more difficult now, isn't it? There's silence. Silence is screaming across the waves here. Let me try and pick somebody. Okay, I'm gonna be nasty now. I'm gonna pick on Asao-san. You were looking away, you see. He's not gonna pick me. I'm not looking. So what do you think? What could be a diagnosis here?
No idea. I haven't learned anything yet.
Don't worry. It doesn't matter. Use your common sense. Why do people fall down?
Not enough blood sugar. I don't
know. If maybe the occasional case of hypoglycemia can lead to falling down. Yes, if the patient's confused. So that could be. So let's use that as an example. So let's say hypoglycemia. So that could certainly lead to somebody falling, and they might then lose consciousness because of low blood sugar, or because they've hit their head as they fell down. Maybe they've had a head injury. Okay, or other injury. And then where does the chest pain come in? Why might the patient have chest pain after loss of consciousness? Okay, Asao-san, I want you, no, I'm just joking. I want you to stand up and fall on the floor. Just joking. But you have to imagine that in your own mind. If I was to fall on the floor right now and I had no loss, I had loss of consciousness,
Yeah.
Why might I have chest pain?
Because you didn't breathe. I don't know.
Hopefully you will have breathed, because otherwise you would be dead. But why might you have chest pain after losing consciousness and falling from a vertical position to a horizontal position? What would be a cause of chest pain then?
You might break ribs.
Is that an English accent I can hear?
Maybe.
Yes. Where did you go to school in England?
Yes, I did.
Whereabouts?
Camberley. You know.
Camberley. Which county was that?
Surrey. Like.
Oh, in Surrey. Ah, I could hear a southern accent like mine. Okay, that's good. Okay, so thank you very much. So the patient might have broken ribs, otherwise called fractures. So let's continue there. Why might then the patient have dyspnea? Still the same question with Asao-san from Surrey.
Well, lungs might be damaged.
Yes, exactly. And therein comes back to this idea of tension pneumothorax. Okay, but now we have a patient who's got perhaps more problems, maybe same problems as the upper part, but maybe in a different order or different cause of the loss of consciousness. And now we've got broken ribs. We've now got a possible tension pneumothorax. The same thing could have happened up here, but the chest pain came first. So the rib fractures won't have come first, although they may occur after falling down. So we've got different diagnoses up here. We've got an MI up here. But that's not featured here, at least at this point. Okay, so the order can change the possible diagnosis. So other causes of falling, for example, could be low blood pressure or something called dysrhythmia, semyaku. Those are just a few examples of causes of loss of, or at least for falling. But other things that can cause you to fall may be a visual problem. You cannot see where you're going, visual problem. Sensory problem. So you cannot feel the floor. Coordination problem. There may be a problem in your home. It may be that there is things in your way, or it's a very dangerous area. So you may well have tripped, maybe a mechanical fall. Okay, so when we hear about patients who fall down, we must always ask, why? Why did you fall? What happened? So that's a separate history taking in itself. Then the loss of consciousness. Can you remember what happened before you fell? What were you doing? And did you hit your head or something like that? How long do you think you were unconscious for? And then other questions like tongue biting and incontinence, because we always think about seizures. Then we ask separate history about the chest pain and the dyspnea in this order to try and make possible diagnoses. Okay. So let's do another example here on a new screen. Let's imagine we've got loss of consciousness, fall, let's do the chest pain again and then dyspnea. So this thing here can be, roof fracture, tension pneumothorax. But why would the patient lose consciousness? What can be a cause of loss of consciousness? Any thoughts? Let's pick Akita-san, Yurina. What can be a cause of loss of consciousness?
Hi.
Good afternoon.
Good afternoon. Brain infraction.
So what? No kosoku?
Yes.
Okay, yes, good. So there may be what's called a stroke. Yes. Any other causes that you know or can think about? You're doing well. Stroke is a good one.
Sorry.
No, don't be sorry. No, this is learning time. It's not to be sorry at all. So I think stroke is a good one, and thank you very much for that. So let me just rub this out, and I will do something slightly different. For any blood vessel problem, this is a nice mnemonic to remember, and it's called, for want of a better word, death. Okay, so dissection. So this means that the blood vessel wall has split, and blood enters into between the two halves of the wall and splits the wall of the artery, and this can have very catastrophic effects on the patient by blocking blood vessels or bleeding. So dissection. Next one is embolism. So embolism is where a blood clot from some other location blocks a smaller caliber blood vessel, and distal to the blockage there is no blood flow, and therefore the tissue dies in that area. So that's embolism. A stands for aneurysm. Aneurysm. So aneurysms can rupture and lead to what we will come on to here in a second, which is hemorrhage. Okay. So aneurysm. And then the final T is thrombosis. That's where you get a blood clot occurring in the blood vessel itself, and that can be for several reasons, but commonly an atherosclerotic plaque ruptures, and then you get a blood clot. Now, another A here can be arteritis. That's an inflammation of the blood vessel, and that can also lead to narrowing of the vessel and ischemia. So if you can remember this mnemonic death, oops, wrong one, let's go back. I want the highlighter, that's the one. If you can remember death, you can remember the major causes of, for example, anything vascular. So blood vessels to the brain, blood vessels to the heart, blood vessels to any structure. Anything that can affect it is by this mnemonic death. So in the example that Akita-san mentioned, she mentioned no kosoku. And for example, that may be from embolism or, for example, from thrombosis. It's an infarction. So that could be a cause of loss of consciousness. But can you tell me any other causes of loss of consciousness? Anybody?
How about the seizure?
Yes, good.
Yeah.
Seizure. Okay. So a sudden loss of consciousness could be from a seizure. Yes.
Perhaps an epilepsy.
Yeah, so that's the same thing, epilepsy. Same difference. Anything else?
How about heat stroke?
Yes, that's more of a it's rather than a rapid one. So let's try and think about this. For example, sudden onset loss of consciousness. This would be the central nervous system problems such as seizure. Oops, epilepsy. Where and then we've also got these other ones. These are cardiovascular, e.g., stroke. That's a sudden onset one. Whereas, or let's say delayed onset loss of consciousness, you might well say, oh, okay, hyper. I think it's better to use the right term. So hyperpyrexia. So body temperature too high, for example, more than 42 degrees Celsius. That might be from heat stroke. What else? Can you think of any other cardiac causes of loss of consciousness? Just stroke? Who can we ask?
AR?
Sorry?
AR? Aortic.
If it was, yeah, you mean aortic regurgitation? If it was part of a dissection and something called cardiac tamponade, then yes. But AR on its own, usually your blood pressure is very high. But it may be associated with other things. So let's put down here aortic dissection. With tamponade. Now, tamponade is where blood accumulates around the heart, and the blood compresses the heart, and therefore the heart cannot fill with blood. Your blood pressure drops, and you die, unless you have a heroic surgeon who cracks open your chest and sucks the blood out and repairs your aorta. That's why we have a surgeon here. Okay, so tamponade is a very catastrophic problem when acute. You can get chronic tamponade, but acute tamponade is deadly. Any other ideas? It's very simple. I think a lot of people always overcomplicate these. Medicine is actually a very simple thing. It's based upon knowing anatomy and knowing basic physiology and a few other bits and bobs thrown in. So cardiovascular things, it's all related to blood pressure. Yeah. So if your blood pressure drops, you're not supplying blood to your brain, and you lose consciousness. Your protective mechanism by your brain is to fall on the floor. That's how you don't die. when you have a blood pressure drop. So it equilibrates the blood pressure and you survive. It's a safety mechanism. So what is blood pressure? Blood pressure is related to your cardiac output. And that's times total peripheral resistance. This is very basic first year physiology. I hope you would agree. I haven't done physiology in many years, but this is what I remember. Now, cardiac output is stroke volume. That's how much your ventricle, your left ventricle, can pump out in milliliters per compression or per contraction. That's the stroke volume times heart rate. So stroke volume times the heart rate times total peripheral resistance gives you blood pressure. So if something impairs the stroke volume, such as something pressing on the heart, it cannot fill with blood, tamponade, your blood pressure drops. If something is obstructing the blood flow out of the heart, like aortic stenosis, you have a reduced stroke volume. That can drop your blood pressure, you lose consciousness. If, for example, the amount of blood coming into your heart is reduced, the heart can't pump out as much blood. Why is there less blood? You may be bleeding. Call the surgeons. You may be bleeding. So that again will drop your blood pressure. If your heart rate goes too slow for whatever reason, maybe from a drug, maybe a beta blocker, your blood pressure will drop and you'll lose consciousness. If your heart rate goes too fast, your heart can't pump as much blood out per unit time. You lose consciousness. Okay? And the total peripheral resistance is related to your ability to constrict your blood vessels to push blood up to your heart. So if you have, let's say, septic shock and your blood vessels are all opened up, you can drop your blood pressure and you lose consciousness. So there's lots of causes of cardiovascular causes of loss of consciousness. Either it's stroke volume, heart rate, or total peripheral resistance, or a combination thereof. Okay, so although I say medicine is simple, it is. The basics of it are simple, but there's many diseases that it encompasses, but the very structure of it is really simple. That's why learning your physiology and the anatomy is so important. I didn't appreciate this until I was into medicine for about, I don't know, 7, 8 years. Then I suddenly clicked. That's why they wanted me to learn this. I didn't know. And you probably don't realize, oh, why do I have to learn all this anatomy? Why do I have to learn biochemistry and physiology? Oh, it's so boring. Yes, it's a bit boring. But when you suddenly get to my level, Dr. Match's level, or even before that, and it suddenly clicks, you say, oh, that's how it's helped me. Then you realize why they have a 6-year curriculum, because you need to know it. Okay, so let's just, does anyone have any questions, by the way? I'm talking too much. Any questions? Because what we've done here, we started off with the order of the symptoms. That's all we've done so far, is the order of the symptoms. And we've been able to come up with different diseases, different it's not a thorough list, of course, but a list of serious illnesses from one pattern, which is here. Then we changed the order and we came up with a whole lot of other problems, some of which overlap. Some overlap, of course, but some are completely separate. And then we changed the order again, and we've got a whole different set of symptoms. Or sorry, it's a whole different set of possible diagnoses. Again, some overlap with what we've discussed. So this is a fundamental important thing, is you need to ask the patient, what's the order of your symptoms? The order changes how you think about the disease. It changes the direction of how you're going to ask the questions to the patient, because you're already beginning to think of that disease. Oh, MI, myocardial infarction, aortic dissection, tamponade, tension pneumothorax. That changes what questions you then ask the patient. Okay. And senior doctors begin to think about the diagnosis from the history, so from the presenting complaints, already beginning to think of the diagnosis, and then focusing the questions towards the patient. Okay. So that's how senior doctors think. So let's go back to here, this first or second slide here. Okay, so our questions are very important. We need to know the order of the symptoms. Very important, the order. What came first, what came second, what came third, if they can remember. And then we want to get the detail of each symptom. And this is very important. This Socrates or OPQRST, very important, because it can help you to think about what diseases cause the chest pain. Then we can ask detail about the dyspnea, that's the breathlessness. And then we can ask the details of how the patient fell down, if they can remember, and the details before they lost consciousness, and then after they woke up from being unconscious. And there are many questions, too much to go over in this discussion because we need to move on. But the detail of each symptom this is essential. Oops, excuse me, wrong one. This one. It's essential because it can, and you say, well, why? Well, it leads you into what you will examine in this patient in more detail. You're going to examine the whole patient. You're going to take more time over particular areas. So if we were to, let's go to this one. So if we were to say, oh, okay, this patient's got, has had a fall. Patient's fallen down. Okay. They've had a fall. So we're going to therefore examine their head because we want to know, have they had a head injury? We're going to examine their neck. We're also going to examine to see if they've got any fractures of their long bones or of their ribs. We're going to basically examine their bones as part of the physical exam. We're also going to, because they lost consciousness, we're going to do a neurological exam and find out, has there been any neurological signs like a stroke? Because of chest pain, also going to examine the cardiovascular system in detail. And because of the dyspnea, this also includes a detailed lung exam. Okay. Now, because the patient doesn't have abdominal symptoms, doesn't mean we're not going to examine the abdomen. but we may not take as much time over the abdomen as other areas. Okay, but it does tell us that we need to be examining those kinds of systems: skeletal system, neurological system, cardiac system, respiratory system in detail. Okay, so that's why we need to be thinking about diagnosis early. And that then leads us into what tests we're going to do later, and what is the order of those tests and the importance of those tests. How much are we going to rely on those tests? It all leads in from the history. That's why it's important. At this point, does anyone have any questions? Please ask away. Yes.
Hi.
Hello.
Yeah. So my question is, it might be a little bit easier way for doctor to ask for about the history when a patient comes with certain pain. But
yes,
when a patient comes to a doctor when he or she has don't have a really good appetite and losing weight, then we cannot use the OBQRST.
That's right.
Pattern. So yeah.
That's right. That's a lot more difficult when they come with appetite loss and non-specific symptoms. It is a nightmare. But interestingly, usually they're not in an acute state. So you can usually take more time to gather the history. And an important point actually is maybe some of you think that history taking is a one-off thing. When they come into the hospital, as they come through, you take the history, owarimashita, finished, hooray, now it's off to the CT scanner, MRI scanner, lots of blood tests, and then they sit on a ward. You come round to see them once a day, say, hello, Mr. Jones, and goodbye. Wrong. Wrong, 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 wrong. If that's what you think, it's wrong. History taking is an ongoing process. It is not just on admission. You're taking history from the patient every single day. When you see them, it's history taking time. Because new information may have come from the patient. Doctor, I have a new symptom. Oh, I experienced this pain overnight, doctor. Or I feel this symptom, doctor. It's more history taking. Oh, really? When did this happen? Tell me more. So that's one example of history taking. You may get a result of a blood test. You think, oh, that's a bit strange. That might be that problem. You go back to the patient and say, have you got this symptom or that symptom? Because your blood test showed us this, and it might suggest this disease. Can I ask you some more questions, please? And the patient says, yes, doctor, how did you know? Well, that's actually a failure of taking the history on admission, but that's another story. But you can use the information you collect from admission time or after admission, go back and take more history to confirm the diagnosis. So history taking is not just at the beginning of admission. It is a continuous process of history, physical, tests, history, more tests, physical. It's a combination of the whole thing. It never stops. So if you thought it was just on admission, think again. Okay? But
okay, thank you.
Yeah. So just going back to what I was saying about the history taking. It's, as I say, it's not just on admission. It's a continuous process. But if you have a patient with non-specific symptoms, oh, I feel tired, doctor. I've got no appetite, doctor. I've lost weight. It's usually not acute. It's not going to kill you right now. It may be a deadly problem eventually. It may be the patient's got cancer or tuberculosis or lymphoma, something like that. But it's not going to kill you on day one, usually. Whereas if you're having a heart attack or a dissection or a pulmonary embolism, that will kill you. And that's why you need to be very thorough, and you need to be quick but thorough and examine correctly to work out the diagnosis quickly. That's the beauty of the history taking. But with non-specific symptoms, you can take more time. You can take a thorough history on admission. You may not get the information you need. You go back and take more history and more history. Examine again, more tests, more history. It may take longer to get to the diagnosis, but it is not an emergency situation. So you need to think in your mind, when a patient comes into the hospital, is this a life-threatening emergency? Mi no gashite wa ikenai. I must not miss this problem. This patient might die. That's the first thing to think about. Boom. Once you're out of that, you can go, take a deep breath, take your own pulse, sit down, have a cup of coffee or a cup of tea. Some of you may smoke, you may want to have a cigarette, maybe not, but relax. Then the patient you know is not going to die on day one. Okay, that's the mindset you need to have. Is this an emergency or not? That's how I split my thinking up into emergency, non-emergency. And most of the time it's not an emergency. They're not about to die on you, but sometimes they are. That's when they come in to the emergency room. And then you've got to be very, very quick-witted, quick thinking. And that comes with not by reading books, not by looking at CT scans. That comes with seeing patients, going to the ER, speaking to patients, examining them in the ER, learning, not just looking at scans and reading books. It's not enough. You cannot be a doctor just by reading books. It's part of the process, but you need practical experience to understand. Okay. Any other questions or thoughts at this point? We've got about 30 minutes left, it looks like. So we need to rush through a little bit more. Any questions at this point? Okay, so let me move on. So we've got this section. So we've done presenting complaints. We've done the presenting complaints section. The details of the symptoms is called the history of presenting complaints. Oops. So we've done that, the explanation of each symptom and the chronology of the symptom. So the next thing is the past, let me write it in full. Past medical and surgical history. Is this important or not? What do you think? Or is it just boring? Oh, it's boring. What do you think? Who can I ask? I've asked Fujimura-san, I've asked Asao-san. Nakagawa-san has spoken. Kabun-san has spoken a lot. Excellent. What about Tanaka-san, Ayako? Have you spoken? Yeah, have I asked you? Yes, I've asked you, haven't I? You've turned your camera off. But let's ask you, what is past medical and surgical history important?
I think it is important because it depends. It's quite important. I think it's important because they have we can determine how good or bad the patient control their symptoms or the illness. So we need to do that.
Okay, thank you. Thank you very much. What about Chihiro-san? Are you there? No? Oh, yes. Oh, you responded.
Okay,
Great.
sorry about that.
Yes, that's okay.
Would you repeat the question again, please?
Yes. Past medical and surgical history. Do you think it's important? And if so, why?
I think it's very important because if you know some medical histories, you might can expect what kind of symptom he or she may have, and from surgical standpoint, like if somebody presenting with abdominal pain, you might can think about this, like a previous history and previous surgery might affect it. I mean, have some like relation to these symptoms.
Very good indeed. Excellent. Thank you. Very nice indeed. Let's ask Saki Kakinuma-san. What do you think?
Yes.
Big voice, please.
Okay. By taking medical history, we can know big diseases they experienced and use the information to diagnose.
Yes. Excellent. Very good. I'm glad. It seems to be that everyone seems to have a good understanding of why the past medical history is asked. Very good. Thank you very much. Thank you very much indeed. Okay, so let's just quickly go over this. So yes, major medical illnesses to be asking about, or what patients may have. Let's imagine that they may have angina pectoris, or they've had MI, myocardial infarction, or diabetes mellitus, or they've got COPD, chronic obstructive pulmonary disease, and so on. Okay, so this may relate to the symptoms they've got now. So somebody mentioned that. So imagine that the patient's got cough and sputum, and they've got fever, and their sputum is green, and they have a history of COPD. Maybe this is an exacerbation of COPD, or maybe they're presenting with appetite loss and weight loss and cough and bloody sputum, and they have a history of COPD. Maybe they've developed lung cancer, question mark. It makes you think about complications of the disease they already have. Or maybe the chest pain the patient presented with and loss of consciousness. Oh, maybe it's related to their ischemic heart disease. They had a new cardiac event. Or the loss of consciousness may be related to the diabetes because they're using insulin, which we'll maybe discuss later. So the past medical history is so important because it may reflect on what's happening now. The past can predict the future, as the saying goes. Okay, so the past history can predict the future. And as you become more seasoned doctors, you will understand and say, this patient could develop this problem or that problem. And then you look clever when the patient actually has that. You say, well, I said so, because you already know about it. And then we've got surgical complications. Okay, surgical complications. So the patients may have had surgery in the past, maybe abdominal surgery, and they present with, let's say, abdominal pain and vomiting and abdominal distension, and they may have adhesions. as an example. Okay. They may well present with what seems to be medical symptoms, maybe neurological symptoms, and they've had a history of bowel surgery. Maybe they had a small bowel resection. And it ends up they've got vitamin B12 deficiency. And they present with neurological signs. It's related to the prior surgery because the doctor didn't prescribe vitamin B12 replacement, as an example. Okay, so medical history and surgical history, really important, really important. And also, particularly cancer. Cancer is really important. It's almost equivalent to tuberculosis. I link those two together because they can present very similarly. So cancer can present with different stages. So early stage disease, let's say stage 1, you're likely to survive very long term. Most patients do. But once you hit stage 4 disease, that means it's spread all over the place. Your chances of survival, does depend upon the tumor, are very low. You have what's called a poor prognosis. Now, if they've had cancer surgery, you should always ask, do you know the stage of your disease when you were operated? Did you receive chemotherapy? Did you receive radiotherapy? What did your surgeon say to you or your medical oncologist say to you? Are you in remission? Because it may be that their symptoms are related to the cancer recurrence. And I've seen that many times. The cancer comes back, they have new symptoms, and you see, breast surgery. When did you have your breast surgery? Oh, I had it 3 years ago and I was given the all clear by my surgeon. But actually, usually all clear is at 5 years, not 3. But sometimes it comes back and there's recurrence. Okay, and then you say, well, what was the stage of the disease then? Blah, blah, blah. How was the histology? They may not know that, the patient, by the way. You may have to pull the old records for that. But the histology can also predict what's going to happen in the future. Okay, so, and I link this together with TB because, as I say, they can present very similarly. Now, TB is a medical problem, but TB also depends upon treatment. Now, if they had a past history of tuberculosis, that's good. But if they didn't have any treatment history, that can recur. So it's the same thing, can recur. So I always ask about, for cancer, the staging, TB, and cancer, what was the treatment that you had? And how long was the treatment for? Was it successful? Okay, so past medical and surgical history are really, really, really important. And I cannot say that enough. So you do need to take a very good past history because it can reflect upon what's happening now. Yeah. Any questions related to this at all, please? Any questions at all? In which case, I will then move on to the next section on the history taking, which is medications. Now, it's also medications and allergies, or because they go together. I may only have enough time to talk about medications because it's a really big topic. Now, it does depend upon your university, but you will have pharmacology training at some point. Most of you will have a minimum of 3 months of training, perhaps up to 6 months, and very rarely a year. But it's very rare in Japan for 1 year. Usually it's 3 months up to 6 months, or somewhere in between that. Now, I can tell you this for absolutely certain. It is not enough to understand anything about how to use drugs in patients. It's more of an introduction than anything. And it's very concerning that medical training at this stage is not teaching you about pharmacology. I did pharmacology for 2 years, 2 years. And I worked hard at it, by the way, but I was able to understand medication, how to use it, or at least the way that it works and the drug interactions in a great more detail than I've seen medical students coming out in Japan here being able to do, and that concerns me. So I want to just go over today, basically, why is it important to understand the drugs? Can anyone tell me why we take a drug history? What's the reason for it? Can anyone tell me?
Can I speak?
Please jump in. I need to take some tea whilst you're talking.
Even if one drug is very effective to a particular symptom, there are times when if you give another drug and then the effects combine, or if there's a chemical reaction between them, then it can result in fatal. It can have fatal results.
Yes, particularly if one drug counteracts the other. Yeah, that can certainly. If one drug is life-saving and the other one has the opposite effect as a side effect, yes, it could do. So that's important. So that's what's called drug interaction. So drug interactions are common, and you should know at least some of the common ones. Good. Any other reason why we want to take a medication list?
I think metabolism body differ in person to person. So we need to understand how much the patients take the drug by, and it's a great measure to understand the how well the liver can work. So
good. So that's a drug side effect, and also the effect that we wanted to have. Is it having the correct effect, and are there excessive side effects? So drug side effects and drug effect. Good. Excellent. What else? Why else do we take the drugs? Let's ask Kawabe-san. Have you got your microphone linked in?
Yes.
Oh yes, great. So why do we take a medication list? Why do we bother to understand the medications?
Because medication has a lot of side effects.
Yep. So side effects, good. Yep.
If we make mistake to take medication,
It's okay. So thank you very much. I think what you're referring to maybe is adherence.
yes.
Yeah. Used to be called compliance, but now it's called drug adherence. Yeah. Thank you. Does anyone else have any ideas why we take the drug history? What about Masuyama-san? Nozomu.
Hi.
Please. Hi.
Hi. Probably we have to check up that the patient is satisfied with the drug's effectiveness or not. And is it too strong or a little weak, or maybe there are many options the patients can choose, many similar drugs. So we don't get all of the information of the drug. It depends on the how to say it depends on the personal body
preference,
bodies. So yeah, maybe we can try other drugs, or yeah,
sure.
there are many things we don't know yet. So yeah, it's important to ask them that what are they using, I think.
Good.
Yeah.
Good. Thank you very much. Yeah. Okay, so we've got a few nice ideas here. So I also want to introduce you to, I think we've got, what, 10 minutes left. So let's just, I want to introduce you to this concept. Every drug must have a diagnosis. Now, you may not believe me when I tell you this, but, oh, excuse me, I have seen many patients come into hospital and they have a drug list. And you say to them, why are you on this drug? And they say, I don't know. The doctor gave it to me. Why are you using this vitamin? I don't know, doctor. Why are you on this tablet? I don't know. And then you look at the doctor's letter, the drug is listed, and you look at the diagnosis, and there is no diagnosis for why they're on that drug, because they don't know either. And maybe the patient was on it by somebody else, or maybe the doctor just started it for a different reason and didn't write it in the notes. No one knows. So every drug must have a diagnosis. So you look at the drug list, A, B, C, D, E. Does drug A relate to any of those diagnoses that you would treat that? Ah, yes, A drug is for this disease. B, yes, that's for that disease. C, hang on a second. What disease would that be for? That's not on the list. So a common one, let me try and think of an example. There's a very commonly used drug called Senocide. Does anyone know what that's used for? Anyone know? It's very easy. It's used for constipation. Okay. Now, constipation is often left off a diagnostic list. I very rarely see a patient who has diagnosis constipation, BIMPI. But it is a diagnosis. It's kind of half a diagnosis because you always need to find out why they're constipated, but it nevertheless part of a diagnosis. But often you'll see patient comes in on Senna and you look down the diagnostic list, no constipation listed. So then you look at the drug and you go to the patient, say, I notice you're taking Senna. Is that right? Yes, doctor. Do you have constipation? No, doctor. Well, why are you taking this drug? Oh, I'm going to the toilet. Okay, now. Hang on a second. Before you took Senna, did you have constipation? Yes, doctor. So you use the drugs to find out the missing history, because they must have it. They must be on the drug for a very good reason. So having a drug list leads to more history taking for missing history. Okay, missing history. Okay, so that's one example. But before this, you've got the past medical history. So, for example, you may see on the diagnostic list osteoporosis, very common problem in the elderly. And you look down on your diagnostic list, okay, there's the osteoporosis. You look at the drug list, where's the treatment for osteoporosis? They've had fractures of the spine, they've had a wrist fracture, they've got kyphosis. Where's the drug? Where are the drugs for the osteoporosis? So we go back the opposite way. Every diagnosis must have well, not every diagnosis, but many do. Diagnosis should have a drug if the diagnosis warrants using a drug. So if you have let's say, osteoporosis, then where is the treatment? Okay, so they should match up. There should be past medical history, drug list. They should match. They should overlap for the treatments. So if you've got a disease which is untreated, that means it's been missed, or there must be a good reason why the patient's not on treatment. Maybe the doctor missed it during a different inpatient admission, or maybe the patient refused to take the treatment or stopped it by themselves. Something has happened. So you ask, I see you've got osteoporosis on your drug list, or sorry, on your past medical history. You've had fractures. Have you ever taken treatment? Because I cannot see any treatment for it here. And the patient may say, oh, no, the doctor didn't say. Or, oh, I stopped that treatment. It gave me indigestion. But you need to have this information found. You need to be the detective to find out why. So it goes both ways. Every drug must have a diagnosis, and then every diagnosis, does it need a drug? And do they match? So that's why the drug history is important, okay, as another reason. Okay, now, other things are about whether the drug has evidence. This is a big topic. There are some drugs which are prescribed that have absolutely no evidence at all, and they are prescribed because it's kind of a culture to prescribe them. Everyone who has a kind of a neuropathic type symptom gets vitamin B12. This is usually by orthopedics prescribing B12 to patients in Japan without any evidence to support using it. So it won't cause you any harm, but it's certainly not something that you need to be taking. Certainly because you have 5 years of vitamin B12 storage in your liver, you don't need to take it every day. So there are drugs which are prescribed which have got absolutely no evidence. So you need to look down on your list and say, does this drug need to be prescribed? Because of avoidance of polypharmacy. We don't want to just keep giving patients drugs. We want to try and cut back on drugs, not give them more unless they need it. So does the drug have evidence that it works? Yes or no? If it is, fair enough for their disease. If not, do they need it, or can we avoid poisoning them further? So cutting back on polypharmacy is important. The other thing is to check the dose. Sometimes doctors make mistakes, pharmacists make mistakes, patients make mistakes. They take too much or too little of the drug, and they end up with side effects. Methotrexate being one of them. You won't know what methotrexate is probably, but some of you may. It's traditionally a chemotherapy drug, but has been used in recent years for treating rheumatologic disease such as rheumatoid arthritis. And you typically give it once a week as a relatively small dose. But if you give it every day, you get bone marrow failure. Sometimes it's written up incorrectly, or there's a mistake, and the patients come in with bone marrow failure from it. Okay, so checking the dose and how often is very important for some drugs. Okay, so that's what I wanted to mention there. Okay, so that's just a few things related to drugs, and then of course allergies to drugs. And that's skin rashes, asthma, something called anaphylaxis, and that's another cause of collapse and loss of consciousness sometimes. Drop their blood pressure with that. So allergies to drugs, again, very important to ask about. Usually antibiotics, but not always. Sometimes blood pressure drugs like ACE inhibitors can do it. So there we are. Now, just before we finish, very, very quickly, other parts of the history taking are family history, and that's for inherited diseases, because it may relate to the presenting diseases. As you know, they may come in with chest pain, they may have a history of hypercholesterolemia in the family, and then social history. And this is, most people think it's just about smoking, alcohol, and drugs. It's not. It's part of it, but there are many other parts to it as well, including where they live, what type of accommodation, do they have any home help, formal or informal, family help, meals, and activities of daily living. It's all encompassed within social history. So please don't think that social history is just tobacco and alcohol finished. It's not. Okay. And finally, there is something called review of systems. And this is a list of questions that you ask to the patient for screening of different diseases. And it may be the patient has not mentioned particular symptoms, but by asking these questions, they say, oh, yes, I have that symptom. And then you go down asking further questions, and you may pick up a new disease or more details of an existing disease that you didn't know about. Okay. So what we've covered in just the time spent this afternoon is quite a bit, actually. I could talk a lot longer, but I'm not going to, because I've run out of time. I'm happy to take a few minutes of questions if you like. Do you have any questions that I can answer for you? Morty?
Just thank you for including past surgical history in the history taking, because many medical people just say past medical history, forget about surgical history.
Yeah, surgery is very important.
Yeah, particularly I said, student, don't forget about the trauma history. Trauma.
Yeah, that's true.
Anyway, that's my comment.
Thank you very much. Thank you. Does anyone else have any questions or comments?
Thank you very much for your lecture. That was very helpful. And I'm really impressed with all the students who answered. Their English is great. And this was probably the most interactive session that we had in a long time. So looking forward to the next class. And I hope the students right now would stay on. It's for upper levels, but I think it'll be great because it will probably be a continuation of what you had just done.
It is, I think, yeah.
Great, yeah.
Okay, so maybe we can continue, from the 8 o'clock. So maybe we have like a 25 minutes break. That's okay.
Yeah.
And just one comment, it's very, very important, particularly like a first, second year student before starting like a clinical clerkship. History taking is very, very, very important, and which often forget in the medical teaching, particularly in Japan. For the United States, what we like the student do is not reading the CT scan or X-ray. The most important thing is history taking and physical examination, which is only thing, maybe not the only thing, but the main thing students need to learn during the clinical clerkship. And I always tell the student, when student rotate to my service, I can see the patient only once a day when patient is admitted. And even a resident, maybe one in the morning and before go home, maybe twice. I ask the student to go 3 times a day, spend one time 30 minutes on the bedside, bring the chair and talk to the patient, not just about disease, but just chat, with the patient.
Chat, get to know them.
Then the patient very like that, they want to talk to, whatever they are. And the student learn actually many things from the patient, not just like a history, the medical issue, but how this patient thinking, positive thinking or negative thinking, what's character. Do you think this is very important for the treatment? So anyway, that's my comment.
That's good. I like that.
Okay, maybe wrap up this one, and then next one, link is different. So
yes, that's right.
Please, maybe 20 minutes later, 20, about 25 minutes, I'm gonna open a new Zoom session. So
okay,
thank you very much. I appreciate it.
Thank you very much.
Okay, see you soon.
See you soon. Thank you very much. Bye.